everyone, this is Dr. Pruett. Today we're going to be talking about one of our very frequent encounters in the pre-hospital setting, discussing which kind of patients can refuse care and which ones do we have authority to force transport on. Hopefully after the end of this talk, we'll have some criteria that are very clear in our minds to help us make these difficult decisions. Really, it comes down to ethical principles. In medicine, there's 4, but the 2 that come into play here are autonomy and beneficence. And autonomy is defined as the legal right of a competent adult to make an informed decision about their medical care. So the key word here is a competent adult that can make an informed decision. This is in contrast to beneficence, where it's not so much the patient's ability to make a decision for themselves, but it's the medical provider trying to do the right thing for the patient. And sometimes these are in line with each other and there's no conflict, but frequently there is a conflict. And this is where our decisions become a little bit difficult. In our state, in New Mexico, we have a very high regard for patient autonomy, where we really allow patients, if they have the ability to understand risks and benefits, to make decisions for themselves, even if those decisions are not ones that we would agree with. We don't force our decisions on other people. So basically, the concept here is that refusal of care is a fundamental right of a competent adult. We don't kidnap patients. We don't force them to do things they don't want to do if they are able to understand the consequences of their decision. To further elucidate this, the New Mexico EMS Act defines our procedures for refusals as a good faith judgment by any provider that the person is incapable of making an informed decision about his own safety or need for medical attention and is likely to suffer disability or death without medical intervention available at a facility. So what we have here is this is any provider who can make a judgment based on their good faith decision that this patient is or is not capable of making an informed decision and understanding the consequences of their decision in a setting where they could reasonably suffer disability or death. To further clarify this, again, it just spells out the capability of making decisions by the patient and also adds the caveat that if the patient has had a suicide attempt or is likely a threat to themselves or others, or a life threat exists, that gives us the authority to take them to the hospital against their will for further evaluation. To put it all together, it's our job to explain to these patients the risks of refusing and ensure that they understand that and are willing to accept those risks up to and including death. So the bottom line, to boil this down, I always ask myself 3 questions whenever I'm encountered with a patient refusal. Number 1, there needs to be an apparent life threat present. If this is a patient where there's no either threat to themselves or threat to others, or something that is likely to cause them disability or death, they don't meet the criteria for forced transport. That answers that pretty quickly. But if there is an apparent life threat and you can make that argument, then the next question is, are they truly able to understand the risks of refusing, and are they a risk to themselves or others? So if you can answer those 3 questions in your mind based on your good faith judgment, if they don't meet those criteria, then you have the ability to make them go to the hospital for further evaluation. Now, I know I've said the word competence a couple of times, and this is a legal definition, and this is something that's decided by a judge. This is something that follows a patient for the duration of time, and it's not something that we have the ability to decide in the field. Now, on the other hand, capacity is a decision that we can make in the field based on circumstances surrounding the patient at the current time. Capacity is not a permanent condition. It changes with the circumstances. So you're evaluating a patient. They could be currently intoxicated. They could have recently suffered a head injury. Anything that would change their ability to understand their circumstances right now falls under the umbrella of capacity. So if you have a patient who is refusing care, in your judgment you think they have a life-threatening injury or illness, it's always a good thought to start with a negotiation. So don't be afraid to ask why. Sometimes the patient answers will surprise you. They might very well know that they do have a life-threatening illness or injury, but something is keeping them from going to the hospital. I've had patients that might be worried about their pets, or they're worried about the security of their house, or they have an important thing at their work, or for whatever reason they're not able to go to the hospital. A lot of times it's fear of financial implications and paying for the hospital bills. So if you can start to understand their reasoning, you can start to negotiate and not have to use force to take them to the hospital, but instead help them explore their options, solve the problems or their barriers to seeking help, and help get them to the care that they need in a manner where you're not forcing your opinion on them, but helping them solve their problems. And if at the end of the day they still end up refusing care, and you do think that they have capacity to understand and they're willing and able to understand the risks of refusing, it's not against the rules to still do the right thing for them. So say someone calls for an asthma exacerbation because they're out of their inhaler. I think the nice thing to do for that patient would be to give them some steroids, knowing that that might buy them a couple more days and help relieve some of their shortness of breath until they can get to their doctor. Or maybe they're having chest pain. You can give them aspirin, knowing that that's going to help with mortality. Or if they have a simple wound, it's still okay to care for that wound while you're there unseen. This is your patient, and it is the right thing to help care for them. Now, the exception in this case would be, say you have someone who has an injury, like maybe a sprained ankle or something like that. I would absolutely not give narcotics for pain and then leave. Nobody gets narcotics unless they're going to the hospital in the back of an ambulance. But simple things that you can treat: asthma, steroids, breathing treatments, wound care. Those things are very reasonable and very kind and highly encouraged to do for patients that need our help. Where this can get complicated, there's always gray areas, and we'll go through a couple of those, and I'll explain my decision-making process in these areas. One of the toughest one is the psychiatric calls with depressed patients who may or may not be suicidal. Sometimes it's a he said, she said kind of situation, and it's hard to really understand whether this patient is a threat to themselves or others. A lot of times when I get these phone calls for refusals, in my mind I'm going through the risk factors. So I wouldn't be surprised if you do end up calling Consortium for help. I would try to have a good picture of this patient's mental health in your mind, because what we're really trying to do, again, is weigh the risk and benefit of letting them decline care. So if you have someone who has a history of depression, is on psychiatric medications, especially if they have a history of attempts in the past, recent relationship problems, recent problems at work, any kind of evidence like Facebook or social media that they have been talking about suicide or harming other people, all of these things are cumulative and add up to build a picture for you how high risk this patient is, and can help you make that decision whether they truly are a risk to themselves or others, or whether they just made an offhand statement in the heat of the moment. It's really difficult when you have one person accusing them of a SI statement and then they're denying it when you get there. So the best thing I've found is just to estimate the risk, and it's always better here to err on the side of having them go get evaluated by a medical professional. Don't forget that if it really is kind of a low-risk situation, but you're not quite comfortable leaving them there unseen, if it's the right hours and you have police there, remember that mobile crisis team is a very valuable asset here, because they can come to the scene, save the patient a trip to the emergency room, and have that behavioral health clinician on site make that evaluation for you. Other situations that can be pretty difficult are patients who might be intoxicated, maybe have had a recent head injury, have underlying dementia, and it's just really hard to get a good grasp on how much they truly understand the situation and are able to make an informed decision for themselves. Another gray area is pediatrics. We don't need parental consent for kids to be treated for drug or alcohol abuse, any kind of sexually transmitted diseases, or gynecological complaint, or for psychiatric care. So if you have a pediatric patient who is wanting to go to the hospital for those complaints, that's okay. But it is important to realize if you have a pediatric patient who has a life-threatening emergency and the parents are not wanting to get them evaluated, parents cannot make bad decisions for their children. And so under the law, if you have a perceived life threat, there is the ability to make that child go to the hospital. So what happens when you do decide that there is a perceived life threat and the patient does not have capacity to understand the risks and benefits, It's still a good idea to try to negotiate. You've treated their underlying illness as best you can. You want to talk to them about why they have to go, and use your verbal de-escalation techniques. So make sure you speak calmly. You don't want to be too overbearing or bossy. You want to be respectful of their circumstances, but also convey that you really care about them and are doing this in their best interest. And try to be honest with them about the circumstances that they're facing. It's always important anytime you're making someone do something against their will to consider safety. If you're getting to the point where you're needing to do physical restraints, I would have chemical restraints ready as well, just for the safety of the patient as well as for the safety of providers. Agitated delirium we've talked about in other episodes, but this is a special case where we are forcing patients to go to the hospital. These patients are usually high on some sympathomimetic substance that's giving them superhuman strength. These are patients that will need sedation with ketamine, which is right now only available through Albuquerque ambulance providers. But it's important for us to recognize these patients and sedate them quickly, because this is a potentially life-threatening illness that can lead to cardiovascular collapse. Just make sure you're monitoring these patients after they're sedated, especially their respiratory drive. Vital signs are vital for any patient that you're having to sedate, or really any patient ever. This is a good thing to live by, but especially for sedated patients, make sure you're monitoring their end-tidal capnography and keeping a close eye on their respiratory status. End-of-life care is another special situation where things can be a little bit gray, but really I don't feel that they are all the time. Advanced directives might be in place, and this is really just a clearly delineated, outlined version of the patient's desire for their end-of-life care, whether or not they want to be intubated and whether or not they want CPR. Sometimes that's written down, sometimes it's communicated to the family. It's important to try your best to reach, if the patient is unresponsive or not able to answer this question for themselves, do your best to try to reach the next of kin and have this talk with them, emphasizing the fact that this isn't the choice that the family member would have the patient make. It's the decision that the patient would make for themselves given in this circumstance. So it kind of takes a little bit of the burden off of the family member having to make the decision. They are the person who knows the patient best and knows what the patient would want in this circumstance. Advanced directives can come in many different forms. There's do not resuscitate orders, meaning that they don't want any CPR. Do not intubate is fairly clear. It means we only do basic life support measures. Typically DNR and DNI go together. Since airway control and CPR, you kind of need both to be effective. You might see orders with power of attorney. That just means medical decision maker. Next of kin would be the next person in line to help make decisions for the patient. And some patients on hospice care actually have medical orders for any kind of life-saving treatment. So that would include IV fluids, antibiotics, special circumstances where the patient has been very clear in very specific circumstances what they would want and what they would not want. These situations can get fairly complicated, and this is a perfect circumstance to call the consortium. That's exactly what they're there for, and they're always happy to help walk you through this decision-making process. I do want to emphasize, though, that the law doesn't necessarily say that there needs to be a physician making this decision. It's the provider on scene who has actually the very same capability under the law that a physician would. It's the good faith judgment of the provider. But consortium's always happy to walk you through the decision-making process with the patient that you have there on scene with you. Just a little tip about when you are making these phone calls. I don't know how much this gets emphasized in school, but when you do call, just to make it a little bit easier, make sure you're given your name and your title, whether you're a paramedic or EMT basic, and which agency you work for. It's really helpful if you state your question up front. So give your name, your title, I'm calling for a refusal, or I'm calling for termination, or whatever you're calling for. Just kind of set the stage so that that doctor on the other end of the line kind of gets in the right mental framework to help work through this. Once you give your bottom line up front, you can start to give this story and just make sure you have any pertinent history and vital signs ready. Especially with the psychiatric patients, it's really helpful if you've already gone through their suicidal risk factors and can enumerate those to help build the picture. As always, documentation is very important. One of the highest risk things we do is allow patients to refuse. And so if you're going to pay attention to any documentation, this is one I would absolutely pay attention to. You want to make sure once you've established this person as a patient, make sure you're documenting vitals very well, a very thorough physical exam. And it's important that as part of your physical exam, you're describing their neurological status. So if you're forcing them to go, make sure you're adequately describing their lack of capacity to understand the risks and the benefits of refusing, or how you think they're a risk to themselves or others. And if you're allowing them to refuse, I would clearly, again, explain that capacity and the fact that they maybe could repeat back to you that they understand that this could lead to permanent disability or death, or however else you want to describe it. And then just outline your risks and benefits discussion with them, so it's very clear that when you left them there, they clearly understood what could happen. So just some quick scenarios here of what if, and these are fairly common calls that we get. One of my earliest ones a couple years ago as a fellow was a 55-year-old male who was actively having a heart attack. This was his third heart attack. He already had 6 stents. He was awake and alert. His vital signs were stable, and he was incredibly clear that he never wanted to go to the hospital again and that he would prefer to die at home, despite the fact that he was actively having a heart attack. In this case, he clearly had the life-threatening emergency, but he also very clearly had capacity to understand the risks of staying at home. And so in this case, we did give him aspirin, but legally we didn't have any grounds to make him go to the hospital against his will. Here's another one with a pediatric patient. We had a 16-year-old female who had called 911 because she was having abdominal pain. Her grandma was her legal guardian, and grandma was on scene and said, "Oh, she'll be fine. She doesn't need to go to the hospital." The girl had been having pain for about 24 hours, didn't have a fever, had very normal vital signs, and grandma didn't think she needed to go. It was late at night, and grandma said if she was still sick in the morning, she would take her in the morning, but she didn't want to stay up in the emergency room all night. And what ended up happening with this one was she did get to refuse based on the fact that there didn't appear to be a life-threatening emergency. Her vitals had been stable despite 24 hours of abdominal pain. The girl is old enough that if it gets worse, she can call 911 again for transport later if needed. And grandma seemed to clearly understand the risks and the benefits here, but there was no life-threatening emergency to tip the scales in terms of forced transport or overriding the grandma's decision. And here's another one that we see fairly frequently in the city, maybe a very disorganized schizophrenic who has decompensated to the point that they're no longer rational and might be yelling or running in and out of traffic, maybe a harm to themselves or others. This is frequently one where maybe they're off their medications, and it's not illegal to be a little bit crazy, but it's not great either when you're to the point where you're risking your life or the lives of others. And so if they don't have the ability to understand the consequences of their decisions and their behaviors, these are typically patients that need to go be evaluated and maybe get on some medication again. Bottom line, when faced with refusals, again, if you can bring it down to these 3 questions, for me at least, it makes it a lot more clear and a lot easy when the circumstances are very unclear. So question number 1, is there an apparent life threat? If there's not, then they don't really meet other criteria for forced transport. But if there is an apparent life threat, then the next question is, do you think this patient can truly understand the risks of refusing? And that's just another way to elucidate capacity. And then, are they a risk to themselves or others? And if you answer no to question 2 or yes to question 3, then that's a patient that probably needs to go to the hospital for further evaluation. Overall, nobody's going to fault you if you can prove that you're trying to do the right thing for the patient. It's much better if you're up there on the stand trying to explain your decision making if you were acting in the best interest of the patient and made them go to the hospital, as opposed if you had a patient with a life-threatening emergency that you left on the scene. So if you abide by the adage to just try to do the right thing, I feel like that's always the right thing to do. And that's all I have about forced transports and refusals. If you have any questions or want to talk about it more, feel free to contact the 7-8 or reach out to me. Thank you.